Welcome back, everybody. We're going to begin the portion of the unit that focuses on vascular physiology. Now, if you look at the top of your notes on page 61, you'll see a list of the functions of the blood vessels. I think a lot of this is kind of obvious at this point for you, but it's important to keep it in mind what their job is, because when they fail, they are no longer able to do these functions. So obviously the really big job of the blood vessels is to transport nutrients throughout the body. And one of the big nutrients we think of often is the ability of the blood to deliver oxygen in order to facilitate aerobic metabolism. Aerobic metabolism is using oxygen to make ATP. So obviously in the whole last unit, when we were talking about myocardial infarction and coronary vascular disease, we were really focused on the inability of blood to deliver oxygen to the myocytes and how that can lead to hypoxic injury and actually cellular necrosis of myocytes. But an important piece of the function of blood is also what they take away. So blood delivers nutrients, but it also washes waste products away. And this is also a very important role. One of our big waste products that gets delivered back to the lungs to get removed from the body is carbon dioxide. The blood vessels are also the superhighways of the body. They help deliver things globally, right? To send things out and throughout the body. And a big one is that they conduct our hormones. And we'll have our endocrine lecture near the end of the semester where we talk about the hormones that travel through the blood and where they go, because anything in the blood, right, will spread out throughout the entire body. And then the blood vessels really maintain the internal milieu of our tissues in that they're constantly sensing the environment and making sure that, we're keeping the amount of blood going through the tissue for normal oxygen conditions, normal pH, and really keeping things happy and healthy for the tissues. Now, you have your notes again, that kind of cartoony picture of the organization of the circulatory system. This is just an image that comes from the Guyton and Hall textbook. And I just wanted to refocus, when we first looked at the cartoon in your notes, we talked about the overall organization, the order of things, right? Moving from heart to artery to arterial to capillary and then into the venous system. But if I could direct your attention to what you're seeing on the slide, this is really looking at the differences in pressure. Pressure is on the y-axis, and then you can see each of the vessels listed in the columns on the picture. So at the beginning of this figure, we can see we're sort of looking at kind of normal blood pressures here. So when we record a peripheral blood pressure, we record the low number, which is diastole, and we record the high number, which is systole. We're going to spend a lot of time in this unit talking about what's happening in the blood vessels during systole and diastole. An important transition occurs when you get to the arterioles. Now, the arterioles, again, are the small arteries, like that have branched off of arteries. Very thick walled. The muscular level of the arterioles is extremely thick. And this is where the pressure drops off. And this is also where we have the most control. So we talk about vasodilation and vasoconstriction. And most of the influence of those changes in diameter as it pertains to the total peripheral resistance of the vascular system occurs at the arterioles. And then we continue to have that pressure drop at the capillaries in order to allow gas exchange to happen. And then pressure has to go down again into the venous system. So some things to remember as we talk about the vascular pathology. When you are on the arterial side of this figure, these vessels have very thick, strong walls. They can handle very high amounts of pressure. Once you get into the venous circulation, now the structure of this blood vessel, kind of the layers of it can be very similar, but the The thickness of the wall gets much thinner. The walls are very stretchy. Another term for that would be they're very high compliance. So the venous system really is twofold. It is both for transport of blood back to the heart, but it's also for storage. Because it has this compliant walls, blood can kind of pool and accumulate on the venous side. So you look down in your notes, kind of identified as B in your notes, we're talking about circulatory pressure distribution. We kind of went through that first section, and now I really want to spend some time discussing systole versus diastole. Now, don't tune out on me here, because I know these words, you've heard them over and over again. So students can kind of feel like, if I hear about this one more time, but this is really important because we're going to look at it from a different lens. So I would encourage you to just think for a second. When you take a peripheral blood pressure and you write down the number for systole and you write down the number for diastole, what each of those numbers means to you. And what I mean by that is, what specifically is systole telling you about the body, and what is diastole telling about the body? Most often, if we had the chance to be in class and I let you guys say this answer out loud, most often answer that I hear is that systole tells you about the heart when it's contracting, and diastole tells you about the heart when it's at rest. The first half of that answer was right. Systole does tell you a lot about the heart when it's contracting. But diastole does not tell you anything about the heart. So it does not equal. Does that picture make sense? During diastole, the aortic valve is closed. And the pressure in the heart during diastole is almost close to 0 millimeters of mercury. What do we write down for diastole? A typical blood pressure, maybe 120 over 80. 80 millimeters of mercury compared to 0 in the heart. It is a very common misunderstanding that the bottom half of your peripheral blood pressure, your diastole, is in any way telling you something about the heart. It can't be. They're physically separated. They're two different chambers at this point. The aortic valve is closed, and the heart is just a saggy bag letting blood drip into it. Out in the periphery, we have 80 millimeters mercury pressure, and this is giving you information about the body. So I'm going to go to the whiteboard, and let's draw out some pictures to truly make sure we understand what we are recording when we record our blood pressure of systole over diastole. Okay, so let's first talk about systole again. That's kind of the easier of the two, I think, because it kind of goes together. So here is my very anatomical heart with the aorta coming out. So this will be our aorta. So the kind of obvious question here is, what pushes the blood through this vessel? And I start here because it's going to matter when we go to diastole. So give this some thought. What actually pushes the blood through the aorta? Why does blood go through? Well, the heart, right? The heart contracts. It generates all that systolic pressure that opens the aortic valve, and blood moves forward. All right, so during systole, the ventricles contract. Maybe let's take some notes on this on the screen over here. So number one, when ventricles contract, we're going to increase the pressure. First we increase the pressure in the heart. It builds, it builds, it builds. And when pressure in the ventricle is greater than pressure in the aorta, then the valve opens. So at this point, once the aortic valve opens, now the left ventricle and the aorta are all one system, right? They're going to share their pressures. They're open to each other. It's one container. So at this point, the high amounts of pressure in the ventricle are going to drive blood into the aorta. So pressure drives blood into the aorta. And that makes sense. So as you drive blood into the aorta, what's going to happen? We're going to see increased pressure in the aorta. And we see that during systole, right? Pressure goes up. But the aorta is not a metal tube, right? It doesn't have zero compliance. And if you start increasing the pressure, the walls of the aorta are going to stretch. And I'm kind of exaggerating this size change for purposes of the cartoon. But as the pressure rises, some of the energy that you generated in the ventricle is going to get absorbed into the elastic stretch in the walls of the vessel. Let me say that again. As the pressure in the aorta rises, that pressure is going to both move blood forward. So maybe I can put green over this arrow so we can say it's all part of this story. It is going to create a pressure gradient to drive the blood forward. But some of that pressure is going to be used to stretch out the walls. And the energy created by the ventricle to generate this pressure gradient, some of that energy is going to be absorbed into the elastic properties in the walls of the vessel. So you can kind of think of the pressure generated in the ventricle ends up delivering both forward flow and the pressure gradient necessary for that and stored elastic energy. Where is it stored? It's stored in the stretch of the walls of the vessel. As they stretched out, that's recoil energy, right? As soon as that pressure starts to go away, that stored energy could be released. So in this way, systole tells you a lot about the heart because the heart is what is creating the pressure. As your systolic pressure goes up, you would expect pressures in the aorta to go up, which makes sense. Like, for example, when you exercise and we have a sympathetic output that stimulates our heart to beat harder and faster, we would expect systolic pressure to go up, right? Because our ventricle is generating a greater amount of pressure. We're going to see evidence of that cardiac action in the peripheral vessel because the heart and the blood vessel are open to each other. Let's now think about what happens during diastole. So let's draw kind of where we ended. So here's our heart, and I'm going to draw the aorta kind of in that stretched state because that's where we ended, right? So here is again the aorta. So what happens during diastole? I'll make this a different color. We'll make diastole purple. Well, the contraction in the ventricle stops, right? The heart begins to relax. And so maybe we can write that. So let's put first, okay, heart relaxes. It stops contracting. And as the heart relaxes, the pressure in the ventricle will be less than the pressure in the aorta, which means the valve closes. So maybe we could even put a little door here to show that the valve is closing. So now we've separated these two, and what's happening in the heart, right? Really, really low pressures, almost zero. All the tension in the walls of the ventricle is going away as the muscle cells relax. But what happens in the periphery? Because again, when we measure diastole, we're taking that measurement out at a peripheral vessel. Does the pressure in the aorta become zero? I certainly hope not. That would be no bueno. Oh, I erased my valve. Here, I'll rewrite that. What happens? Well, blood continues to move forward, right? We want a constant flow in our blood vessel. We don't want blood to stop and start and stop and start. That would be incredibly damaging to our tissues. We want a constant flow. And blood does continue to be driven forward. But what drives the blood forward? We have stored elastic energy in the walls of the vessel. And when the valve closes and there's no longer a pressure gradient pushing into those walls, the walls will recoil. So the walls of the blood vessels act like kind of a little pump. They're the peripheral pump that's driving the blood forward. So vascular wall recoil drives the blood forward. So you could even draw this tube getting smaller as the walls recoil. That helps to maintain the pressures during diastole. So when we first started this conversation, I was asking you about what the numbers mean to you. So let's say you're in a chart and you're in, hey, my patient's blood pressure is 120 over, I don't know, let's say 40, really low. What are we learning here? We're learning that during systole, the heart is generating a decent amount of pressure. During diastole, you are learning about the periphery. This number does not tell you anything about the heart because the valve is closed. The pressure in the heart is probably 0. But out in the periphery, we see very low pressures. That is giving you information about the vasculature, the peripheral system. So let me just erase some of the language on here, and let's look at what happens with disease. And we'll use a disease you guys already know. We can talk about atherosclerosis here. We'll put this over here. All right, so in disease, what happens? Well, we have the heart. Let's make it normal because we're talking about vascular disease. Here's the aorta coming off of the heart. And let's give that aorta atherosclerosis. So I'm just going to draw just kind of black lines on here to represent the plaque. And in the previous unit in the heart, when we talked about plaque, we spent a lot of time talking about how it moves into the lumen and decreases the diameter. But it also makes the walls very stiff, right? Atherosclerosis, the sclerosis part is telling you that it's stiff walls. So if the aorta has a lot of plaque in it, this becomes a non-compliant vessel. That means it's not going to have as much stretch. So what happens during systole? In systole, the heart generates increased pressure and it drives blood into this system. If the walls can't stretch, right? And if you go back to the picture on the left, during normal situations, the amount of pressure generated in the ventricle creates both the forward flow, or maybe we could think about this as like the pressure in the aorta, as well as the stored energy. If you can't stretch the vessel because now you have a non-compliant vessel, all of the pressure in the ventricle is going to be transmitted into the vessel in terms of its forward flow, and none of it will be dissipated into the walls. So you would expect higher than normal pressures because the walls can't stretch. When a volume of a system gets larger, the pressures go down. If we can't stretch the walls during systole, you would expect higher than normal pressures during systole. Blood pressure goes up. Systolic blood pressure goes up. And then what happens during diastole? Does diastole tell you anything about the heart? Absolutely not, but it's going to tell us a lot about the blood vessel. If during systole you can't stretch the walls, then what drives the blood forward during diastole? Nothing. You have lost the vascular pump. There is very minimal elastic recoil. So when somebody has vascular disease, their diastolic pressures become very low because they can't maintain that driving pressure. So during peripheral vascular disease or having atherosclerosis in your blood vessels, systolic pressures get higher and diastolic pressures get lower. And we record this value as the pulse pressure, PP. And that's in the very bottom of page 61 of your notes. It says pulse pressure, and we record this as systolic blood pressure minus diastolic blood pressure. From this discussion, I hope you can appreciate that pulse pressure, or the difference in systolic to diastolic pressure, is really driven by both the kind of ventricular stroke volume, how hard can the heart pump and beat and drive pressure into the system, and the compliance of the aorta. The compliance of the aorta and the ability of the ventricle to pump both come together to deliver kind of pulse pressure. So with disease, as someone has atherosclerosis, stiffening of the walls of their arteries, you would expect elevations in pulse pressure, greater differences between systolic and diastolic. So high pulse pressures are a pathological sign. This is a sign of something going wrong in the system. So you kind of typically see higher pulse pressures in patients with atherosclerosis. This is also something that occurs normally with age. We'll talk about why the blood vessels get stiffer with age at kind of the end of this unit, but they do. The blood vessels get less compliant as we age, so it's kind of a normal phenomenon that happens with age that our pulse pressures begin to rise, because as we age, we again lose the ability to get that stored energy in the walls of the vessel to help drive diastole, to help maintain pressures during diastole. Let's go back to the PowerPoint slide, and I just want to show you this in more of textbook images because I think that works better for some students. So here you can see the phenomenon in the blood vessel during systole. The left ventricle is driving blood into the system. It's creating forward flow to deliver blood right to our systemic organs. But as that blood is being driven into the system, we are stretching the walls and storing elastic energy in the walls of the blood vessel. When the left ventricle drops its pressure and the aortic valve closes, the blood continues to move forward because of the elastic recoil in the walls of the vessel. So that's just a little mini intro again into the organization and function of the circulatory system, and also getting your mind to really think about the vasculature as its own important aspect of the pumping of the blood through our body. And really giving some thought to what we actually write down. I'm hoping that I can take you to this next level, and it will happen more in phys activity and cardiopulm. But when you're taking a blood pressure, you aren't just taking that to write down a number. You are taking a blood pressure to gain important information about their cardiac function when you look at the top number and their vascular health when you look at the bottom number. I'm going to make this kind of just its own little separate intro, so that if you go back to this video, you know kind of where to find it. So I'll make this one a little shorter and then finish Friday's lectures in a separate video on starting the disorders of arterial circulation.